We don't have that many data that would go with all of the novel agents for survival. And indeed, we don't, and I don't think we will have a very solid power-focused studies that will really give us the clear answer, yes or no. And then I know that the topic about disease modification is emerging more and more, and there is a dispute and debate, what does it actually mean? Is it a treatment that is able to revert the trajectory of the disease and basically stop it from progression? Certainly, that's what we want to achieve. But is it also a treatment that could give us a significantly meaningful clinical impact and prolonged survival? And that's probably what it is as well. So we have so far seen the data coming from JAK inhibition, and because we have the longest experiences with ruxolitinib, that had emerged initially at the pooled analysis of comfort studies that showed that indeed the treatment with ruxolitinib decreased survival by about 30% risk of death. And then that was followed by other retrospective studies. Probably the largest one was a pull-out data from Medicare claim for services that took very large amount of myelofibrosis patients and basically divided them into 3 large cohorts with those who were diagnosed after ruxolitinib approval, so 2012, 2017, and showed these patients actually had unreached median survival versus those that were either diagnosed during the same period but never been exposed to the drug, or those that were diagnosed before, which actually they had medians of 44 or 14 months only, respectively. So that's a meaningful prolongation of the survival. We kind of, because of the non-having significant power, we cannot really say, hey, this is how the drug improves survival, because there is not really much of a surrogative endpoints on markers. We don't see much of an improvements in fibrosis. We don't see much of improvements in allele burden. We certainly don't see any reversal of going into acute leukemia. But what we have seen is actually improvements in patients' lives, quality of life, symptoms, spleen. They live longer. There has been publications by Ruben Mesa and other MPN experts about improvement in metabolism, cholesterol profile. So we simply improve their lives, and that actually translates into them living longer and living better. So that is one first thing coming from ruxolitinib. That has been followed by other JAK inhibition. Of course, all of these studies were cut short in the early phases, even in the pivotal development, because of various FDA holds on kind of other backlash these agents had. But nevertheless, for example, we had some data suggested by Claire Harrison on fedratinib. We had data that emerged for pacritinib suggestion, and then momelotinib. That's an agent that's not approved. However, the study Simplify-1, Simplify-2 that actually didn't lead to its approval, but already showed that these patients, either in a frontline or refractory setting, had unmet survival. With the Simplify-1 at 6 years, this patient didn't meet the survival, which is an extremely prolonged survival we have seen before. And in Simplify-2, median over 3 years. Those were patients that were intolerant or basically failure to ruxolitinib. So that is also not seen before. We're definitely going to be looking into this with the novel agents. How would the combination with the BET inhibitor would prolong this? There are data emerging in terms of improvements, fibrosis, cytokines, megakaryocytes differentiation, and all of those sub-points that should give us more of the survival, but I think that's something to be determined.